Hello, leaders of the world. Welcome to Spread Love in Organizations, a podcast for purpose-driven healthcare leaders striving to make life better around the world by leading their teams with genuine care and love. I'm Naji, your host for this episode, joined today by Dr. Doug Bruce, Associate Chief of Clinical Affairs at Boston University School of Medicine and Director of Primary Care at Boston Medical Center. Prior to those roles, Doug transformed healthcare in the New Haven community, focusing in the largest health center in New Haven on quality and value-based care, which resulted in significant savings for Connecticut, Medicare, and the community. Doug was also Chief of Medicine at Cornell Scott Hill Health Center and Associate Clinical Professor of Medicine at Yale University. He is a global expert in substance use disorders in people with HIV and hepatitis C. He has published widely on the topic of substance use disorders and HIV. He has provided technical assistance to CDC, NIH, and the United Nations. Doug, I am so honored and humbled to have you with me today.
It's great to be here. Thanks for inviting me.
I would love to hear your personal story from childhood to becoming an expert in HIV and hepatitis C, living with and helping some of the most touched countries by both those pandemics. What defined your journey and the incredible leader and physician you are today?
That's a great question. So I grew up in the Cambridge, kind of Boston area as a little kid. And I grew up and had lots of pulmonary problems, actually. So I had lots of asthma and was in and out of the emergency room all the time. And so I had some really good pediatricians and some not so nice pediatricians. And so at an early age, I thought, you know what? I want to be a doctor. I want to be one of the nice ones, but I want to be able to help people. I want to be able to bring joy and comfort. I realized that what stood out in my mind as a child was not, oh, this doctor has more knowledge than that doctor, right? It was more just, oh, this doctor seems to care about me. This one seems like I'm a widget. I wouldn't have said widget when I was a kid, but it was kind of the feeling. So I, for a long time, felt like I really wanted to be in healthcare. My faith is really important to me. And I realized when I was working in the public hospital system. So I went to the University of Texas Southwestern Med School in Dallas, and I worked at Parkland Memorial Hospital, which is a big county hospital system. And I was taking care of marginalized populations, of groups of people that kind of, you might think of, were forgotten by the system, and began at that time, it was the AIDS epidemic, was working with people with HIV, people with substance use disorders, and saw all kinds of things that I felt like there were great inequities and great trials and tribulations that people were facing, and that one of the jobs of being a physician was to be an educator, but also an advocate. And so after I finished my training in Dallas, I went to Yale University and did a graduate degree in philosophical theology because I wanted to read widely and think and be very reflective about the care of those groups of people. And then started working with the LH program and providing street level care for substance users and people with HIV. And from that, began developing programs and then working internationally with marginalized populations to try and systematically make things better for people who may not be able to advocate for themselves.
You have served, Doug, in countries hit hard in moments where few innovations were even existent for those diseases to treat those patients. Can you share with us your experience, stories, learning that you take with you today leading in healthcare systems in the United States?
Yeah, so I guess two things stand out. One, I spent a fair amount of time going back and forth to Ukraine. What's happening there is a tragedy. When I was in Ukraine, one of the trials that we faced was how siloed healthcare is. And we know that healthcare can be siloed in many countries. And so my time in Ukraine taught me that creative ways to try and overcome seemingly impossible silos. So just concretely, for example, in Ukraine, if you take care of drug addiction, you're a narcologist, and you're not allowed to prescribe medications or offer any treatments outside of your narrow scope. So like, unlike in America, right, I'm not a psychiatrist, but I legally could prescribe psychiatric medications. In Ukraine, if you're a narcologist, you're not prescribing treatment for tuberculosis, even if your patient has tuberculosis. You have to get a special doctor, a physiatrist, who will do that. And then that person is divided between those who do it on the inpatient system and those who do it on the outpatient system. So I kind of learned in that environment just the critical need to begin asking questions, to talk not just to government officials or healthcare officials, but stakeholders. And I had known that in the AIDS epidemic days in the 90s, and the importance of stakeholders, and the importance of voice and people, giving people agency and voice. I think what I learned differently was also that sometimes the way to get to the truth is you have to just talk to so many different people. And that's what blew my mind. When I was in Ukraine, I didn't understand the limitations, and I didn't, because people were not forthcoming. I represented a government, or I represented a university, and people felt that they had to answer me a certain way. But when I would go talk to drug users or people with HIV in the community, people were very forthcoming. They're like, no, this doesn't work, or this is the real problem. And like a classic example was when I was in Kherson, Ukraine, and we were just talking about like TB adherence rates, and it was really difficult to understand like what the problem was, because on one hand, like there are no problems, but eventually we got to the realization of, oh wait, you can just walk up to the pharmacy at the TB hospital and buy part of a TB regimen. So what we found out was, like, if you were a substance user, you would go and get admitted to the hospital. You had no treatment for your heroin problem, so you got sick, which meant that you left. But you had started some treatment. You knew treatment was important. So after you left, you could go to the pharmacy, but TB treatment was 4 medicines. So you can't afford 4 medicines, so you buy 1 medicine. And so that helps you feel better until you get drug resistance. And so it was kind of this systematic problem, but it was very difficult to get at it through one lens. And so I think that was one thing that was really important to me. And I carried that with me when I went to Tanzania, and the need for stakeholders. So an example of this was, so in Tanzania, there's a big heroin epidemic that's kind of really fed into the HIV epidemic. And we had a situation where those most at risk for HIV were female sex workers who are also injection drug users. We had very, very high rates. Like in the survey samples that they had done, like over half of the women had HIV. So we're trying to get them into treatment, on meds, you name it. But when you looked at the clinics were mostly men that were providing services. And so what did we do? We had to go out and actually meet with the women and talk to them and find out like what's going on. And they brought up just very logical reason, right? Like, well, the clinic doesn't have the hours that are convenient for me, right? Because the clinic had morning hours. The women were sleeping because they'd been up all night with their trade over the evening and using substances. So we had to think about, well, how do we lower the threshold so that women can get in? How do we create a safer environment? What do we do with the men that are loitering around? How do we create an environment that's safe for women? And that was based on the feedback from the women.
Those are powerful examples that you've led. So how do you ensure like this curiosity, but also this need actually to go on the field, understand what's going on, and bringing it back and change the system? Because you practically had to change systems to make this work for patients.
Yeah. So, I mean, I guess you have to tailor it, right? Like to your point, just because someone recognizes the need doesn't mean that they're willing to help. I mean, an example of this is we were showing that the tuberculosis rates among the patients in that first drug treatment program in Tanzania were very, very high. It was not surprising. It was one of those things where you know that there's a high probability that this is going to be the case. Substance users are using drugs together. They're in closed environments, inside, poor ventilation. HIV increases your risk of tuberculosis. So the probability is that there's going to be TB among the substance users. So there was no active program to search for TB. So one of the early programs we did in Tanzania after we set up the drug treatment program was to check for HIV, offer HIV therapy, But then it was to start trying to be active in searching for tuberculosis. And so a student of mine went out there and started doing active case finding, and the teams in Tanzania supported this. So they were all really interested in this. And part of the team's interest, as you can imagine, was they didn't want to get TB. And so it was kind of playing off the enlightened self-interest of this is a real material patient concern. But if there are high rates of this, this is a real material concern for all of the healthcare workers in that environment. Because, I mean, there weren't N95s floating around for everybody to wear for TB prevention, right? The main TB prevention is great ventilation, open windows, staying outside where UV light kills it. So that program found that there were high rates of TB, like not as high as South African mines, but like 20 times higher than the national average of Tanzania. So very high rates. And eventually, it's not surprising, right? So you change your infection protocol, infection prevention protocols, you have better ventilation, you don't put people in isolated environments. And eventually, actually, the TB program from the university hospital system in Tanzania started spending time taking care of patients. And so it changed the system. But in this case, it was playing off on that enlightened self-interest, which also paired with the patient need. But then we tried to get, external funding from a separate government agency that, for all intensive purposes, you would have thought would want to fund this, because their enlightened self-interest would be like, oh, like you can get credit for this. But they didn't want to get involved because a different agency was funding the larger work that we were doing. And so they were worried about, they never said this, but it became apparent that they were more concerned about who got credit for the activity than the activity itself, which is very disappointing. So I wasn't able to change them, but they're much bigger than me.
Well, yeah, and it touches to all those lenses we both learned in class. Obviously, this is a huge impact that you had in countries with tremendous need and in moment of crisis, obviously in those countries. I would love to get another leadership learning from you as you led teams there. So you had students, you had physicians who were working with you, and it's kind of potentially also relatable to so many folks. And you went through the COVID pandemic yourself as a healthcare provider. How do you lead teams in such moment of high pressure, tension, emotional struggle, and really life-threatening diseases that you're dealing with?
That's a great question. So I think probably the most important thing that I did in Tanzania was to come in humility and say to the teams, because I'm a guy from the United States coming in, and I'm foisted upon the people there, and they're smart physicians there in Tanzania, and so it can be very off-putting if you're, a academic in the local university there in Tanzania, and some guy shows up from the West and says, "I know more than you do," right? So what I had to come in initially even in the beginning meetings to say was, I'm only here because I've done this before. I have a body of knowledge. And so my job is to impart that knowledge and to work with you. But you have to figure out how this is going to be contextualized in Tanzania. I'm not Tanzanian. I don't know the local politics. I don't know how to do this here, but we're going to work together to be successful. And so I told them from the outset, there will be a day when I don't come to Tanzania anymore, because you won't need me, because you will be the experts. And so I think that resonated very strongly with them, because they had been through, as you can imagine, a series of kind of US government funded activities where people come in and kind of tell people what to do and set it up. And it's not as value driven from the people there. And so what I saw my role as was just, I'm kind of your consultant, I'm your information person, and I'm really here to support the team, but you're going to actually contextualize it. And so a lot of that then became more about empowerment, more about working with the leaders to say, so like kind of an example was they were very worried about overdosing patients, which is a legitimate concern. This was a methadone program in Dar es Salaam, Tanzania. So they are keeping the doses really low. And so what that happens is if you don't give somebody adequate replacement therapy, they continue to use heroin and engage in risk. But they were afraid to go up on the dose because they thought, well, if I give the person more methadone and the person continues to use heroin, they could overdose, which kind of is a logical fear. But the reality is, as you go up on the methadone dose, they go down on the heroin dose. So I said to them, look, you all are very smart people. Why don't you just set up a small mini trial? Just take some proportion of the patients, go up on their doses and see what happens. You don't have to make it a clinic-wide policy, but just use it as an opportunity to learn. So they did that, right? And this, I'm not like announcing this. I mean, this is just like private conversations with people. And they did that. They went up on doses. Patients stopped using heroin. And they were like, this is amazing. And then the next thing I know, they have generalized that throughout the system. And then they're really dosing patients. But again, it wasn't about me coming in saying, this is what you have to do. It was just, let's have a conversation and let's talk about our options. And why don't you consider this kind of a pilot project? And so I think humility is the most important thing that I learned in interacting, especially in international projects, because so often people are coming in again and just kind of telling people what to do. And then that's so devaluing, right? But as I talk to them and said, like, you're the experts. How do we do this in Tanzania? Like, what are we facing? How do we address this? I think it was very empowering. They eventually set up training programs there where they were training additional physicians and who are now leading other programs, which was exciting. But that's something that I then took back to Boston and to other places of just never underestimate the information and the power of the person that you're meeting with, regardless of education, regardless of position. They have something to teach you. And that by valuing that person and partnering with that person, you can make a lot of change, more change than you thought you could.
And it's a great pivot to my next question. You talked about humility, empowerment. These are really strong words as a leader. And the last years, you've been focusing on innovation, operations optimization, practice transformation, like all those large change management projects in academic medical practices in the US. So what is the main challenge you're facing today, and how do you lead through those large organizational changes?
Yeah, inertia is a huge problem. I'm just amazed at how physicians, nurses, medical assistants, administrators really almost feel like the system can't change. Or if the system can change, they view it as 1 or 2% on the margins. They view it through the current lens that they're passionate about: volume, value, finishing my charting, right? Not spending the evening doing that. And so I've found it challenging to kind of help people understand that, wait, should you reconsider the entire paradigm here? You're living in this soup, in this swimming pool, whatever you're in. Maybe you should get out of it. Like maybe we need to completely rethink things. And so some of that has then been, as I always do in a new environment, you spend a whole lot of time just talking to people, surveying the faculty, getting feedback, and trying to create an open door policy. And then also trying to help people understand, look, I'm not going to take it personally. If you come and tell me that the system is dumb and it's broken, like that's fine. I want information, and I want information so that we can make it better. But I would say like inertia is a big thing. And the pandemic, in many ways, because the pandemic was this push into the lives of people where people felt disempowered. They felt hopeless. Like there's this external factor and I can't fight against it. And I think certainly where I'm working now, people have transferred that into their work environment some. That, my clinic got flipped from in-person to telehealth. I didn't have control over that. Or alerts keep coming up in the electronic health record and I can't control that. And so there's this sense that I'm powerless. And because I'm powerless, I'm not really engaged with change management because I'm kind of hopeless about change. And so a fair amount of what I've been trying to do is find some small wins to show people that change is possible, but change is possible when we work together. Change is not really possible if it's Doug Bruce by himself trying to make change, right? That's completely ineffective. It's as we work together and come together that we can make change. But fighting against inertia has been painful.
And this is a very interesting insight because, as you said, pandemic has challenged all of us, right? And many would think that it challenged us in a way to change that now will be sustainable change, right? Like from work from home and the hospitals, all telemedicine, the speed of developing drugs, etc. But I'm hearing from you, the state of mind of healthcare providers today is not that. Like I heard hopelessness, we're not powerful enough to make those changes. Why do you think that is? We know there is a huge mental toll on healthcare providers, and many times I've shared it before. We applauded them in the beginning of the pandemic, but actually didn't change much of the struggle they go through after a couple of months, right? So what do you think is happening, and how can we do it as healthcare leaders across the different healthcare industries?
Yeah, well, I think one of the things that I've been trying to do is actually apply some of those lessons that I learned in Tanzania into academic health centers, because academic medicine is a very hierarchical system where people don't feel like they have voice or agency, and promotion systems and things can be somewhat opaque, and so trying to give people an opportunity. And so some of that is like, and this is seemingly silly, but I think people have found great value in it, is personally replying to the emails that people send me, right? Like I've heard what you said, or taking time to, you have a question, well, let's set up a call. Let's have a conversation about this. Do you want to meet in person? Do you want to meet on Zoom? Again, it's really trying to be responsive. And then to be honest, I mean, the thing that I've been trying to tell people is like, look, I'm not going to lie to you about this. I'm going to just tell you where it is. And it could be that your issue is completely legitimate. Unfortunately, like right now, we don't have resources to address it, or we can't address it. We don't have the technology. Or it could be like, I've got this fire over here and we have to address this fire before we can do this. And the faculty, I think, at least in the feedback they've given me, is that they've been very appreciative of the transparency and the honesty, because that builds trust. And so then when there's some trust, and then you say, we can do this. Like, hey, like we can, like there's a pathway forward. We can make this change and make it happen. Well, people start to say, well, Doug's been honest before. Maybe he's being honest about this. Maybe he's not just saying this, like people have said in the past, to try and motivate us so we see some more patients. So I think building trust through transparency and honesty is really important if we're going to start trying to help healthcare providers get out of some of that inertia and hopelessness and feeling that they don't have voice and they don't have power. And so we have to create opportunities for voice and agency. And then we have to listen to that. And then we have to be responsive to that.
I would give you one word, and I would love to get your reaction to it. So the first word is leadership.
I guess when I think of leaders, I think about people who get on the front line and work in the middle of the battle, right? I don't think of leadership as detached from what's happening. The most success I've had in leadership has been on the front line, learning from people, teaching people, and changing the system there.
Innovation.
I think increasingly when I think of innovation, I would say I used to think of that as change, like modify the current system. And I think of that now as creativity. I think more and more of innovation as what's a better system? Like just what's a completely better system? And so I would say I'm learning in that space, again, having a breadth of people speak into that is really important because of the realization that I could say the current system is bad, let's make a new system, but it shouldn't be my new system. It should be our new system. And so, well, who are the our? And so often like the physicians in the practice will say, well, it's what the docs say. Like, well, what about the nurse practitioners and the PAs? What about the nurses? Well, what about the medical assistants? What about the front desk staff? What about the stakeholders? What about the patients who are the actual people who are coming, right? And so the more that we branch that out and the more that we give agency and voice, I think the more we can be truly innovative and have something totally different, which is what I'm now thinking more about as the word innovation, just making it completely different and better.
IP, intellectual property. And it comes from a debate we had.
Yeah, I think so. I really do believe that you need to protect intellectual property. So I've changed my view of this, right? Like I was in the probably more supportive of ACT UP and like get meds to the world. I still believe that we need to find ways that we can get medication across the globe to everyone who needs it. The very reason that we did a methadone clinic in Tanzania versus anything else was because it's the cheapest thing to do. It's also the most effective, which is kind of rare that the cheapest is the most effective, but it was incredibly effective. But because it was cheap, we could treat more people. And, you know, in public health interventions, it's really about treating large numbers of people if you're going to make a difference, right? If we only vaccinated 10% of America against COVID, we really wouldn't be having the kind of successes that we're having now. So public health interventions, especially with infectious diseases, require large scale interventions. So I think that if we don't protect intellectual property, people will not be innovative. They will not create completely new drugs. They will not create completely new solutions. I mean, I'm amazed when I started taking care of people with HIV, they were fistfuls of pills that were incredibly toxic and had horrible life-limiting side effects. Now today, like, I mean, this is crazy to me. It's easier to treat HIV than high blood pressure and diabetes. Like, if you had asked me in the 90s, in the middle of the AIDS epidemic, you know, someday HIV will be easier to treat than diabetes, I would have said you're nuts. Like, that's just not going to happen. But it happened because let's be honest, right? There was a profit motive in doing that. The same with hepatitis C. Like, I never thought that we would be curing people as easily as we can now with hepatitis C treatment. And so I want to preserve the intellectual property that helps foster innovation for companies to make a profit, because that's why they're innovating in the first place. I just want to find a way where we can, that those medications don't just stay in rich countries, and then the patients that I care for in other nations of the world, who are people too, and who have, I think, dignity as people and rights to good healthcare, that they can't access it just because they were born in a foreign country, right? That just doesn't seem right to me. But I do fear that if we just do away with IP and these things, or we fight against them, then people will say, well, why, you know, we'll invest our money in real estate or something. And I want people to continue to invest in developing great medications, especially when there are some serious diseases still in the world that we need people to be innovative about. I mean, malaria, for example.
Yeah. What about spread love in organizations?
Well, I think that, I mean, that kind of goes to everything that we've been talking about, right? One of the things I tell healthcare providers who can be so serious sometimes, I'm like, you know, if all we do when patients come is tell patients how they failed in everything, they failed to lose weight, they failed to take their medicines, they failed to like go get a chest, whatever. Like, who wants to come see anybody that's that negative? Right? Who wants to come see the healthcare provider who's like, yeah, you failed, come back. And I mean, my own life, right? So my doctor told me once that because I was like, I don't want to exercise, why don't you just give me a statin for my cholesterol? And the guy looked at me and was like, you're a smart guy, figure it out, like just go exercise. And I didn't go see him for a year because I was like, I wasn't exercising. And then I like exercised 2 weeks before I see him, so I could answer the question and be like, yeah, I'm exercising. And he didn't even ask me. I was so upset. I was like, really? But that's not necessarily a productive healthcare relationship, right? And so when I think of spreading love, I think of spreading love both among staff. So one of the things that I do often is I try to remind every member of the staff their vital importance. So I'll tell the front desk staff, like, you're the first point of contact when people walk into the clinic. Like, your role is incredibly important because that's going to set the tone for the rest of the visit. If I'm mad after the front desk, like, I'm going to be mad when I talk to the medical assistant. I'll be mad when I talk to the nurse. I'll be mad when I talk to the doctor. So, and then empowering medical assistants, like, you're getting a proper blood pressure has like real material healthcare consequences. Like, your role is really important. And so I think part of spreading love is helping people know that they are valued and that they're not just parts of a machine and that I can flip a switch and easily replace you. It's like, no, like, you're bringing you to work today and you're valuable and you're important and what you bring is important. And so I think as people feel that value, as they feel that, like, coming to work is really important. I need to go to work today. Well, why? Because I'm really important. That then spreads to patients, right? If I'm really happy and experiencing joy in my job because people here value and care about me, I spread that to patients. And that's infectious. I mean, I like infectious disease, right? But like, it's really infectious. And so I think we just need more and more to do that. And it just starts with saying, you have dignity as a person, and I need to treat you with dignity. And as I do that, I'm spreading love.
I love that, Doug. And, I thought a lot, and you kind of touched on the 4 letters that I sometimes use with love. It's listen, observe, value, and empower. You literally talked about all of them. Thank you so much for those amazing examples. Any final word of wisdom for healthcare leaders around the world?
I would say, be creative, be a listener, and be humble. I've had high school educated substance users teach me things. I've had people with multiple doctorates teach me things.
Thank you so much, Doug, for being with me today. Thank you all for listening to Spread Love in Organizations podcast. Drop us a review on your preferred podcast platform. Connect with us on SpreadLoveIO.com or on LinkedIn. Most importantly, spread love in your organizations and spread the word around you to inspire others and amplify this movement our world so desperately needs.